There's only one hormone from the parathyroid glands. They are again located, there are four of them located posteriorly on the top and lower parts of the back of the thyroid gland. They only secrete one hormone, which is the parathyroid hormone, which in turn has only one function, which is to raise serum calcium levels. So the parathyroid hormone is only released in two instances. One, when the calcium levels of the blood drop. Second is if there's a tumor growing on it. Okay. So this is the anatomy. So it's again attached. So this is what I mean by when you take out the thyroid gland, can you pluck them out? No, because if you pluck them out, where's the blood supply now? And where are you going to put it? Are you going to staple it to the... Okay, so when you remove the thyroid glands, one or more, one or both, one or the entire or portion of the thyroid gland, they are inadvertently removed as well. So there's only one problem here in each problem. So we've got hyperparathyroidism or hypoparathyroidism. Let's start with hyperparathyroidism. So if it's a hyperactivity of the parathyroid gland, what happens to serum calcium levels? It'll be high. So the problem would be, of course, signs and symptoms of hypercalcemia. Simple as that. What is the normal range of your serum calcium? 9 to, well, not really 11, 9 to 10 point something. Yeah, I think it's 10.5 or 10.2, something like that. All right. There are secondary types of hyperparathyroidism. We talked about this briefly. It was mentioned in chronic kidney disease. So in stage 4, stage 5 kidney disease, they develop hyperparathyroidism, secondary hyperparathyroidism. The cause of primary hyperparathyroidism is almost always a tumor. There's a tumor growing on one or more parathyroid glands. So here on the anatomy, look at how small the parathyroid glands are, like the size of a booger. So when a tumor grows on it, the tumor doesn't have to be on all four. Tumor growing on just one parathyroid gland is enough to cause hyperparathyroidism. Manifestations for... To make it easy, I will just test you on whatever manifestations are listed here, unless you insist on testing from the fluid and electrolyte chapter. Okay, so this is good enough. So the manifestations mentioned here: apathy, fatigue, muscle weakness, nausea, vomiting, constipation, and cardiac arrhythmias. These are all manifestations of hypercalcemia. So we'll skip the ST and T wave changes, meaning the cardiac rhythm manifestations. We'll reserve that when we get to module 8. So for exam 2, I will simply focus on what's on these pages here, right? Now, take note that hypercalcemia can have complications. This can lead to kidney stones, which can cause, of course, obstruction in the renal system and also in the urinary system. So kidney stones, bladder stones, urethral stones can also form as a result. Exactly where did this calcium come from? So when you have hyperparathyroidism resulting in high levels of parathyroid hormone, where exactly did this calcium come from? Why did it increase in the bloodstream? Very good. So calcium from our teeth, from our bones, are resorbed. Okay. So they are broken down by the parathyroid hormone. That's how it raises serum calcium levels. Keep in mind, only 1% of our calcium is in the blood. 99% is stored away in the bones and the teeth. So as a result, it will cause demineralization of the bones or the teeth. So that's how serum calcium levels increase. And as a consequence, there will be bone pain, tenderness, joint pain, back pain, pain on the joints, okay, and then the shortening of the stature also as because the vertebrae will lose height. There's also increased peptic ulcer and pancreatitis. So if you remember, or no, um we haven't done Cushing's disease yet, but in Cushing's disease, wherein the patient has high calcium levels also because the patient has muscle wasting, there is increased incidence of peptic ulcers and pancreatitis in these patients. So, yes, main manifestations are hypercalcemia, but of course, think about the consequences, complications of demineralization of the bone, and of course, the kidney stones that will form. Management, because what's again the majority of the cause of hyperparathyroidism? A tumor growing on one or more parathyroid glands. So therefore, what's the treatment? Surgical removal of the tumor. And can we just remove the tumor and preserve the parathyroid gland, considering its size? Impossible, right? Because the tumor is so big, how are you gonna pry it out of the parathyroid gland? It's attached to one or more parathyroid gland. Except of course if the patient has the secondary form, which means we use drug therapy, because the patient in secondary hyperparathyroidism, of course, has chronic kidney disease. So here, since the surgery is the recommended treatment, is the pre and post-op care different from thyroidectomy? Exactly the same. Okay, so the patient may undergo subtotal or total or radical thyroidectomy. That's the treatment. Okay, there's really no procedure that says parathyroidectomy. It's actually thyroidectomy. Okay. Now, until the patient has surgery, we have to treat the hypercalcemia. Now, there are several ways to lower serum calcium. One is hydration. Hydration, though, is never given alone. It's always paired with diuretic therapy, meaning, yes, we will give the patient diuretics, but we will also give them large amounts of fluid. Look at this, daily intake of 2,000 or more. This is main purpose is to prevent stone formation, calcium stone formation. We give diuretics also because what will diuretics do? Okay, this will remove the fluid, right? But is our aim here to lower calcium or to remove fluid? It's to lower calcium. We actually want to eliminate calcium because yes, we learned that diuretics cause loss of potassium, correct? But if you read the textbook, it actually causes loss of all electrolytes. We just emphasize potassium because that's the most critical. But in truth, the patient who takes diuretics actually lose sodium, potassium, calcium, and chloride all at the same time, even magnesium. So we give them together, fluids plus diuretics. But as far as diuretics, keep in mind that thiazide diuretics are avoided though. So all other types of diuretics can be used except thiazide diuretics. So give me one thiazide diuretic. Very easy. No, furosemide is loop diuretic. So it's in the name, thiazide diuretic. So what's the name? Hydrochlorothiazide, HCTZ. Okay, that's the thiazide diuretic. Mobility, keep in mind that the patient has hypercalcemia, correct? Where did this calcium come from again? From the bone. So do we put them on bed rest or do we encourage mobility? We actually encourage mobility because if you put the patient on bed rest, no stress on the bone, it will worsen the bone breakdown. Okay, so we actually encourage mobility, not like sports. I mean, we have them walk. Small, not really heavy exercise. Diet, obviously, we increase the potassium? I mean the calcium intake. No, doesn't mean we also restrict it. Okay, so we just have the patient, no change in the calcium in the diet, same as what they're already used to. But if the patient already has peptic ulcer, patient of course will be given antacids and protein. Now, the patient has constipation, right? We saw that in the manifestation. So what will be included? Prune juice, stool softeners, and again, physical activity, okay, to promote regular bowel movements. And because the patient's bones are weak, yes, while we encourage activity, do we also have them fall or do we handle them rough? Okay, so make sure everybody understands that the patient is prone to fractures, okay, because of the weakening of the bones, the joints. And that's it. So what is the management again? Surgery, right? It's basically surgery. But until they get surgery, what do we do? Fluids with diuretics, avoiding which diuretic? Except that thiazide diuretics and what's in the diet. Okay, and then we encourage prune juice to softeners. All right. All right. So one thing briefly here. So if the patient has severe hypercalcemia, look at this. If the calcium levels are 13, 15, so the option here is, of course, you can either give the patient calcitonin, it would be mentioned here, or also the drug is called Aridia. Let me see what the generic for Aridia is. I keep forgetting. Aridia. Pamidronate, sorry. Pamidronate or alendronate. You remember biphosphonates? For osteoporosis? Yeah, alendronate. Okay, so the IV form is pamidronate. So this can be given for acute episodes like this. So let's say the patient's serum calcium level is 17, 15. The patient will be at risk for cardiac arrest. So we give IV biphosphonates infused over 2 hours. Okay. And don't forget, we still give fluids plus diuretics, okay? And then we add biphosphonates IV, and we can also give calcitonin. All right, so these are the options for severe hypercalcemia or in hypercalcemic crisis. Or if needed, the patient will be placed on dialysis, short-term dialysis, once or twice to remove calcium. And here's a warning about cardiac complications and also airway because this will cause also severe hypercalcemia can cause bronchospasm that may close the patient's airway. Oh, pamidronate is here. Okay. So please don't forget these drugs. These are the common drugs you'll be seeing in actual practice, all right? Especially pamidronate. Any questions on hyperparathyroidism? Okay, let's go straight to hypo. So this is the other problem. So if we had high calcium and hyperparathyroidism, what do we have here? Low calcium. Okay, so remember one of the complications after thyroid surgery? What is the result again? Besides hypothyroidism, they will also develop hypocalcemia, correct? All right, so because why did that occur after thyroid surgery? Okay, because we also took out one or more parathyroid glands. Okay, so surgical removal will definitely develop hypoparathyroidism. Another cause is vitamin D deficiency, okay, meaning the patient may not have a thyroid issue, but they may have a vitamin D issue. How do we get vitamin D besides eating it? Okay, from the sun. So patients who are living in, let's say, what, give me dark areas. Okay, so patients with little or no sunlight, right? So they will have vitamin D deficiencies. What are manifestations again of hypocalcemia? Tetany Okay, so we have Chavostics and the Trousseau sign. Okay, two signs of tetany. Other manifestations, of course, are not just spasm of the arm and wrist, but also of the joints. And there's dysphagia, photophobia. As you can see, we see dysphagia or difficulty swallowing or airway closure in both hyper and hypocalcemia. It's present in both. And both will also cause cardiac dysrhythmias and even seizures. Okay, we know about Chavostics and Trousseau. Management. So what do we do? Patient's calcium is low. Calcium. Okay, so very good. So we give calcium. Okay. If it's oral, we have to give calcium with vitamin D. Okay, very, very good. And then if it's IV, of course, it can be given alone. You can give calcium gluconate or calcium chloride. If the calcium is severe, it's a 6 or 7, that's severe already. If it's around 8 or between 8 and 9, that's mild. We can get away with giving them oral forms of calcium with vitamin D. Now, for vitamin D deficiency, there are two forms of vitamin D. There's active vitamin D, activated vitamin D, and there's also inactive uh, vitamin D. So we have ergocalciferol. This is vitamin D. We give thiazide diuretic. Remember earlier, we avoided thiazide diuretic with hyper, right? Hyperparathyroidism. This one we can actually give it because what does thiazide diuretics do? Prevents the kidneys from eliminating calcium. Okay, so that's why we avoided it in hyperparathyroidism. This time we can give thiazide diuretics. We can also give recombinant parathyroid hormone, although this is not very common. Diet. What are foods high in calcium? Okay, so please read this here. Calcium, phosphorus is prescribed. Milk products and are high in calcium. Go ahead, finish it. They are restricted because they also contain high levels of phosphorus. Okay, so yes, on first thought, you would go for dairy and milk products, yeah? But actually, what does this say? They're actually, yes, they're high in calcium, but they're also high in phosphorus. So that's counterproductive. So we can't give these in the food. We restrict them. Doesn't mean the patient can't have them. Yes, they'll eat them, but at lower amounts. Okay, because of course, when you add phosphorus, then of course that phosphorus and calcium can't be on the same place at the same time. So one has to go. So if you give high phosphorus, then you lose calcium and then vice versa. Yes. All right. We can give okay. What is aluminum hydroxide? Is Maalox, right? Antacid. And there's the rationale there. Helps excrete phosphorus, so you retain calcium. Okay, because who are again at risk for hypoparathyroidism? Those are who had thyroidectomy, correct? Okay, so watch them for development of hypocalcemia. And in emergencies, especially after thyroidectomy, we have what drug made available in case the patient develops tetany? Calcium gluconate IV. And here's your teaching. If the patient is on calcium supplements, usually for this case, since it's maintenance, the patient may have up to 4 doses of calcium. Just make sure you don't give the fourth dose at bedtime or too close to bedtime, because otherwise, what will happen to the patient? Have problems sleeping, plus the patient may develop constipation. Okay? Um, because your doses should be, it's usually 3 doses, meaning breakfast, lunch, and dinner. But sometimes the doctor prescribes an evening dose. So just make sure they take it not too close at bedtime. That's about it.